Good evening, everybody. Thank you for joining us this evening. So just to introduce Juanita to you all before we get kicking off this evening, Juanita, I've had the pleasure of working with for quite a long time now, Juanita, probably since about 2014. Juanita was most recently employed by a mainstream secondary school in the London Borough of Hackney. Her role within this setting was to manage and deliver services to students with SEN within the school. And in practice, this means she's had a very broad caseload of students who present with disorders of communication, such as autistic spectrum disorder, dyslexia, dyspraxia, and developmental language disorders, amongst others. Juanita works with essentially everybody. There's no end to her skills, and we're absolutely delighted she's able to join with us this evening. She is now a director of the London Autism Assessment Practice, where she regularly undertakes multidisciplinary diagnostic assessments for autism. So there's lots of knowledge coming at you this evening. So without further ado, Juanita, I'll hand over to you. And if you want to share your screen, we'll get going from there.
Thank you. Well, welcome everybody to this evening's webinar. And I'm going to be talking to you about autistic spectrum disorder versus developmental language disorder. We're really going to start with a view of, well, what is developmental language disorder? Now, it's a very big topic, and I've tried to give you a potted view of it, but there are three key things that I think it's really important that you know about DLD, as I'll be referring to it. DLD is the term that's now widely used amongst the speech and language therapy profession and beyond to describe a child or adult who has difficulties either talking or understanding language. So the difficulties can be both receptive and expressive. And in some cases, children or individuals will have both. It's very much classed as a hidden disability that currently affects approximately 1 in 2 children in every classroom. So you can see how wide the diagnostic presentation is of DLD, and it can go on to have quite an adverse and significant impact upon a child's literacy, their learning, the way in which they develop friendships, and ultimately their emotional well-being. Therefore, it's absolutely key that children with DLD are identified as early as possible and that they receive the required support from a range of professionals, including speech and language therapists and specialist teachers, who can make and often do make a considerable difference. Now, why the term DLD? Those of us who have been around for a long time will have heard of terms like developmental aphasia, specific language impairment, and so on and so forth. And these were used prior to 2016, when Dorothy Bishop, an eminent psychologist and expert in language, worked as part of a group or a project called the Catalyze Project. And they really wanted to clear up the difficulties that we had with terminology. So it was determined that DLD would be the term used to describe children who had what we formerly called a specific language impairment. But the most important thing about this little category of children was to recognize that their language difficulties were standalone difficulties and were not the result of any other biomedical condition, such as a brain injury or an acquired aphasia, a neurodegenerative condition, a condition such as Down syndrome, cerebral palsy, hearing loss, ASD itself, or any form of intellectual disability. Now, in terms of the frequency of DLD, well, I've already said it's quite significant, and current research suggests that approximately there are 2 children in every classroom who will have DLD. In fact, a study by Norbury in 2016 suggested that at least 7.5% of children in education had a DLD. So that's a very significant number in terms of this particular presentation. What are its causes? Well, we know that DLD tends to run in families, and twin studies have indicated a strong genetic influence with regards to DLD rather. But this is often the impact of many genes rather than a very specific mutation as identified by Bishop. However, I'd like to stress at this point that the view that DLD could be caused by parents or caregivers who fail to engage or talk to their children has absolutely no support. What about the neuroscience of this? Well, in terms of the neurobiology, there is no evidence of any brain damage in the majority of cases. However, Leonard and others have found that there might be subtle differences in terms of the size of various regions and proportions of the brain in relation to grey matter. But so far, this is found to be very inconsistent from child to child. So currently, there are no biomedical markers for DLD. So how does DLD relate to other conditions? Well, we know that it commonly occurs with attention deficit hyperactivity disorder and dyslexia. And of course, much has been written in the literature about the overlap with autism. And I'm going to talk about autism and the overlap a little later. However, what it's absolutely crucial, and I've really got to emphasize this point, is that children with a diagnosis of DLD do not have the social deficits which are central or core to a diagnosis of autism. That's not to say that sometimes some children with DLD are described as having some autistic features. Now, that's hardly surprising when you consider that if you have a significant difficulty in understanding and using language, that's obviously going to impact upon your ability to communicate in a social context with others. And so that can make some children with DLD appear to have some symptomology that one would associate with DLD. But it's the social point that we're looking at. It's the ability and the willingness to interact, the social motivation and interest in using language that often differentiates between a child who's on the spectrum and one with a DLD. What I'd like to point out is that despite the fact that DLD is so prevalent within our population, there is a considerable difference in the help available out there, children who present with a DLD versus perhaps a condition such as autism. And we see these differences persisting well into adulthood, where although both autism and dyslexia are often talked about and recognized disabilities that the majority of people will have heard of to some degree, they have some sort of marker for it, there's very little awareness of DLD. Now, as I've said, when we think about DLD and its links with other conditions, I have mentioned the fact that it's very closely associated to dyslexia. And indeed, there is a view that where a dyslexia ends, you might well have a developmental language disorder. So they are part, if you like, of the same condition. What we know is that many children with DLD often meet the criteria for dyslexia. And I've come across this many, many times in my own work. So I find that if a child has developed literacy and they can undertake the functional aspects of reading, there are nearly always problems with comprehension of what they have read. And it has been my experience that these difficulties can often be overlooked, and that their failure to comprehend what they're reading might be misconstrued as inattention or difficult behaviours. And we've got to acknowledge that currently, as part of their training, teachers are not regularly taught about DLD. I'm moving on now to think a little bit about DLD in terms of employment and mental health. Well, we know that in terms of employment, a diagnosis of DLD has to be taken very seriously, because we see an increased risk of unemployment, which also moves on to have an impact upon that young person's ability to be as independent as they possibly can in adulthood. Even so, we find that those who continue to have ongoing problems, although they hold down jobs, these might tend to be of a relatively unskilled nature. There is a view that better recognition of DLD within the school system would allow young people's areas of skills to be developed further, so that they are not overlooked if they don't do particularly well in terms of the more conventional academic outcomes. And I can think of quite a good example here, in that a young man that I worked with many, many years ago, I ran into the other day in a local pizzeria, and that he was very significantly language disordered and had a developmental language disorder. And he felt absolutely delighted to be working in the pizzeria. Now, some of us might think that that was a fairly menial job, but in terms of the degree of language difficulty that he had, that was a great success for him. What about mental health? Well, we see that generally children and young people who have less significant DLD don't have as many issues in terms of their mental health. But this contrasts with the almost 64% of young people with DLD and persisting language difficulties that go on to show some externalizing behaviors, so difficulties with aggression, conduct disorders, and so on and so forth. And or they might internalize their difficulties, so they become withdrawn, more solitary, and so on. For some young people, these difficulties self-remediate once they reach adolescence. However, we have found, and research suggests, that teenagers with DLD are 2.5 times more likely to report symptoms of depression than their typically developing peers. And that was identified by Conti Ramsden and Botting back in about 2004 to 2008. I think what's very interesting, though, is that much of the support offered to children and young people who have mental health difficulties tend to be talking therapies. And it goes without saying that if you have a communication difficulty, then accessing a talking therapy is not going to be readily easy for you. Now, what's the intervention, DLD? Well, law in 2015 advised that for interventions to be effective, they had to be of high quality and of sufficient duration. So here we're looking not at blocks of support that a child or young person might get for half a term or a term, that might not be long enough to make any real impact upon their language disorder. The quality of the intervention is also incredibly important, because you require support from an individual who is highly skilled and has the knowledge base to support your particular difficulties. Now, we have had ongoing debates about this, but there have been various controlled trials within schools that have shown that interventions delivered by teaching assistants who are trained and regularly supported by speech and language therapists can bring about significant improvements in language and literacy. I think the key to that point is that the TAs need to be trained and they need to have the support from speech and language therapists. And there is going to be a difference in terms of perhaps the severity of the DLD as to whether or not the TA could realistically carry out a program for a young person or child with such complex language needs. Therefore, you have groups of children and young people who need much longer term and more specialist support for their language issues that unfortunately are likely to persist despite intervention. And this has been particularly found to be the case for those children and young people who have ongoing challenges with receptive difficulties and for whom their receptive language disorders are considerable. There is a very strong feeling that in terms of DLD, much more needs to be known by members of the general public in terms of what this condition is. Again, Bishop, who has championed the cause of children and young people with DLD for some time, has highlighted on numerous occasions the low rates of research compared to the frequency and severity of DLD within the population. Hence, there has been a huge initiative which has recently been renamed. It was known as Rally, and many of you might have heard of Rally. It's now raising awareness for developmental language disorders. This is a campaign which has fought tirelessly to increase awareness of key facts about DLD. They run a YouTube channel, they have a website, they produce fact sheets and numerous supporting materials to share information about this highly unrecognised condition, but one which is so prevalent and affects so many children and young people. Now, at this point in my talk, I'm going to turn to autism or autistic spectrum disorder. And again, I mean, this is a topic which is very close to my heart, and I could talk about for a very long period of time, but I'm trying to give you an overview of this condition and where we see an overlap in terms of DLD. So ASD is essentially, it's a complex neurodevelopmental disorder, and it's characterized by repetitive patterns of behavior and difficulties with social communication and interaction. We often see the symptoms of autism presenting in early childhood, and we know that this can go on to have quite a marked effect on daily functioning. Now, the term spectrum refers to the wide range of symptoms, levels of disability and difficulties that commonly occur in people with ASD. While some children and adults with ASD can perform all activities associated with daily living, others require a far greater level of support to perform even the most basic activities. ASD is described in the Diagnostic and Statistical Manual of Mental Disorders, commonly known as DSM-5, where the revision back in 2013 saw autism, Asperger's syndrome, pervasive developmental disorders not otherwise specified, falling under this umbrella of ASD, as opposed to the separate disorders that they once were. Now, ASD occurs in every racial and ethnic group and across all social economic levels. However, we know that ASD is more likely to develop in boys than girls. So this is something that has long been seen. The girl phenotype in ASD is an entirely different talk, and I'm not going to go there today. But when we're thinking about some of the common signs of ASD, when we're looking at infant children, we can see how quite often they might become overly focused on particular activities and objects. A big thing that we look for is the quality of their eye contact and how well that's modulated. Whether they are showing any real interest in communicating with their parents or caregivers. We sometimes see in children that their development appears quite normal, for want of a better phrase, throughout the early stage of their development until possibly their second or third year. And then we begin to see changes, and sometimes quite marked changes, as some children regress and they show a total indifference to social engagement, and in many we might see a loss of language. Now, the severity of ASD can vary greatly and is largely based on the degree to which social communication and the insistence of the sameness of activities, so this is this repetitiveness and this reluctance for change in terms of not just activities but surroundings, and lead to these ongoing patterns of behaviour which have a marked impact upon the everyday functioning of the child. So, social impairment and communication difficulties. Well, we know that people with ASD find social interactions difficult. The mutual give and take nature of communication and interaction is what they find particularly challenging. And we refer to this as the social reciprocity. It's a big area of deficit. Now, children may fail to respond when they're called. They avoid giving mutual eye contact with other people. And you might see that they only really interact with other people to achieve their own goals. So they're very much on their own agenda. We can also typically see that children with ASD struggle to understand how to play or engage with other children, or they might not be interested in playing with other children at all and prefer their own activities. As they grow older, young people and adults with ASD struggle to understand how other people are thinking, how they're feeling, and also have difficulty in talking about their own feelings. Now, the range of language need in ASD is again vast. We can see verbal abilities whereby the child or young person has no speech at all, to those who have speech and a great deal of it, but the speech is somewhat inappropriate, awkward, tangential. We also see that children with ASD may have very delayed or indeed disordered speech, and that can affect their ability to construct language, to develop appropriate vocabulary. We might see that they're quite repetitious. They rely upon scripts to support their communication, or they give answers to questions that seem totally unrelated. Additionally, we see that people with ASD have a difficult time understanding and using non-verbal cues. So the natural gestures that you or I might use and the body language that we rely upon to support our communication doesn't come as second nature when you have a diagnosis of ASD. So for example, a child with ASD might not necessarily understand what you mean when you wave to them. We also see difficulties in terms of the sound of the speech and the rhythm and its prosodic features. So we talk about people on the spectrum having difficulties with intonation. They might sound a little robotic in terms of what they choose to talk about. Their choice of topic might be quite limiting and narrow, and they may show very little regard to the fact that the person to whom they're talking doesn't share that interest and possibly has no interest at all. So, what disorders are related to ASD? Well, we know that there are certain genetic disorders such as Fragile X and tuberous sclerosis that commonly appear alongside ASD. But researchers keep on looking at this particular area and are finding that there are other genetic mutations that have not yet been identified. And we see that perhaps some of these syndromes, which are becoming a little more known about, might indeed account for up to 20% of all autistic cases. It has been proven, however, that people with ASD have a higher than average risk of having epilepsy, and children whose language skills regress quite early in life, so before the age of 3, they seem to appear to have a risk of developing epilepsy or seizure-like brain activity in at least 20 to 30% of those children. And seizure disorder is something that, again, in the literature is often talked about, certainly with some of the older adults. So how do we assess for ASD? Well, first and foremost, if a child or young person is screened to see if there is a possible ASD, that might well lead to a more comprehensive and detailed assessment, which is undertaken by a multidisciplinary team. Now, the team can vary, but it might include a psychologist, pediatrician, psychiatrist, speech and language therapist, occupational therapist, and other professionals who commonly diagnose and work with children with ASD. What we expect to see and what has been recommended according to the NICE guidelines is that a thorough developmental assessment of the child's development is undertaken with parents or caregivers alongside an observation of the child's play and their social communication and interaction. So this commonly means that in order to be diagnosed, a child may undergo the ADI, the Autism Diagnostic Interview, or the ADOS, which stands for the Autism Diagnostic Observation Schedule, and we're now on version 2. A question that I'm certainly commonly asked is, well, does autism change over time? And I think what's really important to say is that there is no cure for autism. However, if the child or young person gets the right therapy and behavioural interventions, which is designed around their specific challenges, that can substantially improve their difficulties and ultimately their prognosis. Ideally, treatments that coordinate therapies and interventions that meet the very specific needs of the individual are what we're driving for here. And it's long been agreed by professionals working in this area that the earlier the intervention, the better the outcome. But this said, for many children, their difficulties can improve with age, albeit with the appropriate support and education. This said, during adolescence, some children might need a greater degree of support as they transition to adulthood, because change is a big area of difficulty for young people on the spectrum. So we see that people with ASD, they usually continue to need support as they get older, but this very much depends upon the severity of their difficulties and has an impact upon whether or not those people with ASD are able to work successfully and live independently or within a supportive environment. So, how different is DLD from ASD and other neurodevelopmental conditions? You will already have heard me say that autism is a disorder which is characterized by social deficits, namely difficulties with reciprocal social communication and interaction and impaired communication. So the DSM-5 tells us that in order to diagnose autism, there has to be deficits within communication and social interaction, which you see across multiple environments, as well as restricted, repetitive behaviors, as well as repetitive interests and activities. This is very much the crux of the difference between DLD and ASD. A child or young person with a diagnosis of DLD does not have or should not have that reciprocal social interaction difficulty. Indeed, they very much want to interact, they want to use language, they want to develop those relationships, but they have very specific and often severe challenges in organizing language, understanding language, and developing appropriate vocabulary to support their language. Now, structural language impairment is something that we commonly talk about when we're looking at both ASD and DLD. Now, in ASD, a language impairment or a language disorder is commonplace, and it's long been accepted and established that this is so. So approximately 63% of all children diagnosed with ASD will have a language impairment or language disorder. So we do see these very specific difficulties in the way in which a child or young person with ASD structures their language. So they have difficulties, they can have difficulties with phonology, grammar, semantics, and so on and so forth. Very similarly to a child or young person who presents with DLD. However, in ASD, it's the way in which the language is used, and we refer to this as pragmatics. That's a key feature of the disorder, and is again a big differential between a diagnosis of ASD and DLD. So as I've been saying, individuals with DLD, just like those with ASD, they can struggle with syntax, morphology, language processing, vocabulary, working memory, literacy, and so forth. But the main difference that we're looking at here is social communication. In DLD, the challenges generally relate to problems expressing one's thoughts and comprehending what others are saying, while in autism, the problems go way beyond that. And there are difficulties in terms of the motivation to use language, the pragmatics behind language, understanding the meaning behind interacting with language, and difficulties understanding non-verbal communication, and ultimately the motivation to use language for social purposes. So I thank you all for listening. We are now about 20 to 8, so that's 40 minutes. I'm rather pleased I haven't gone too much over time, because I was very keen to ensure that we had sufficient time for questions. So I'm going to stop sharing my screen now and join you all.
Perfect. Thank you so much for that, Juanita. That was really, really helpful. Always a pleasure listening to you and your expertise. Always learn so much from you. We have had some questions coming in, and as is always the way, I'm pretty sure that as we start talking, there'll probably be a few more, but well done on the timing. You've done remarkably better than I do on mine, that's for sure. So if we could just kick off from the DLD aspect. Person here has asked, what tests are done to diagnose DLD? Are there scores and percentiles? And can I ask a SALT to assess my child for this? So quite wide ranging, but yeah. I'll give that one to you first.
Okay, well, I would expect that if you suspect that your child does have a developmental language disorder, that they would be assessed by a speech and language therapist. The assessments that we use vary quite widely, but there is a very specific assessment called the Clinical Evaluation of Language Fundamentals, and we're now on version 5, so that's the CEL5, that's routinely used to determine whether or not a child or young person is presenting with a disordered language profile. So if I were referred a child or young person and there was a suspected developmental language disorder, the CEL5 would be my test of choice if I could, because it allows the therapist to look quite broadly at receptive language as well as expressive language. So you're getting a view of both. And then, of course, it has various subtests that look more specifically at vocabulary, semantics, working memory, and so on and so forth. The way in which the child or young person constructs language, and to some degree their understanding, well, definitely their understanding of language. So that's what I would expect. And my comment would be that if you feel that your child is presenting with quite marked difficulties in that area, then I would request that they are assessed by a speech and language therapist. It's hard to be cut and fast about the actual percentiles, but quite clearly, if you do an assessment like the CEL5 and the percentile ranks are pretty low, then that is going to give rise to a degree of concern. However, often in children or young people with DLD, they might present with what we call a spiky profile. So you're going to see perhaps some percentile ranks that fall within the low average or even the average range, but then there'll be others that are well below what is expected for their age. So it's this rather sort of bumpy, uneven profile that often gives rise to a diagnosis of a DLD.
So in relation to ASD assessments, obviously you're involved in them as well, and there's a couple of questions around that. So just moving away from DLD, and then we're coming back to it as well. Firstly, can a SALT diagnose ASD? And I know you touched on this in your presentation, but I think it would be helpful just to expand if people perhaps don't understand your role in the MDT assessment for ASD, because they've said, I thought that only a clinical psychologist could assess for ASD. And then the second follow-up, I'll actually let you answer that first, and I'll follow up with the next one.
Okay, well, in terms of diagnosing ASD, there have been quite seismic moves forward in terms of ensuring, or perhaps, promoting that the diagnosis is undertaken as part of a multidisciplinary assessment. We have moved away from the days where one particular professional diagnosed ASD. There needs to be a consensus view. And so as a speech and language therapist, on my own, I could not diagnose an ASD, but as part of a team, and I currently work with a clinical psychologist, an educational psychologist, and an occupational therapist. As part of that team, we can diagnose ASD. I think, speaking from the perspective of a speech and language therapist, the nature of a diagnostic assessment for ASD really does focus in on the way in which a child or young person is communicating and the way that they are using their language, as well as looking at their play and their interaction skills and so on and so forth. And therefore, a speech and language therapist is ideally placed to support the team in looking at that aspect of the child or young person's development. And that's exactly what I do in the team that I work in.
Similarly, around the DLD ASD, we know there's lots of confusion around it, Juanita. Somebody's asked here, an anonymous asker, as DLD is about language development, is it possible that a young child could be misdiagnosed as having ASD? And then they've just put for context, a boy who is diagnosed at 4, who has language difficulties, but is sociable and tries to interact with other children. However, his play is quite repetitive and he's sensory seeking. So is there any opportunity that it's possible that, there might be misdiagnoses between DLD and ASD? Have you got any thoughts on that?
Well, it has been known to happen. And as I said, I think in the talk, sometimes there are some similarities in terms of the way in which a child with a DLD might present in terms of their social interaction. It can appear that there are some quite marked challenges in that area, which we understand to be related to their language. However, it can sometimes happen the other way around too, where we see children who have been diagnosed as having autism, and then perhaps when you look at them more clearly, you can see, well, actually, this seems to be a child who is very much wanting social interaction, and they appear socially motivated, they want to play with other children, but they don't have the linguistic ability to support that interaction. So, yes, misdiagnoses, unfortunately, can happen. And this is part of the reason why now we try very hard to ensure that, we're not looking at these children down our own particular lens. It's a much broader, holistic assessment so that you reach that consensus. And sometimes it's not possible. I mean, sometimes, you know, in our team, we see children and we're not sure. And we suggest that perhaps they come back in 6 months' time after they've accessed a greater amount of speech and language therapy, for example, to see if that makes any difference in terms of the way in which they appear to be using their language, and then bring them back and have a little look. I mean, you know, we did so quite recently with a little girl who we saw probably 6-7 months ago, and we really couldn't make up our minds because her language was emerging and so the picture of her was changing. But she has since come back, and although she has acquired way more language, there is still quite a marked difficulty in the way that she uses that language. So for us, she's now sort of tipped over into the ASD diagnostic category. You can have ASD, but you can't have ASD and DLD. They're separate diagnoses. You can have ASD with a language disorder. So we talk about this. We talk about these comorbid difficulties, such as a language disorder, appearing alongside an ASD, not a DLD, for the reasons that I've explained during the course of this talk. However, it's quite possible within an EHCP to have both diagnoses of ASD and language disorder, and you would very much want that recognised because of the impact that can then have on the nature of the support that that particular child requires. It's not necessarily just about meeting their challenges with ASD. When you have a comorbid language disorder, it's absolutely important that support is afforded to that child within the EHCP to further develop their language, because indeed that can be having quite a marked impact upon their ASD. And so it's really important where it's felt that that occurs, and we know that it's more common than is given credit to, that support for that child is warranted in the plan. Absolutely crucial.
I think there's lots of miscommunication, isn't there, around developmental language disorder and language difficulties that arise through autism, and that's what we're getting lots of questions about in the Q&A. And as I thought would happen, as we're chatting, lots and lots of questions are coming through, and it's going to be difficult to explain this perhaps you know, as we're talking, but there's a question here around just what we've talked about here: developmental language disorder, autism, and somebody's actually asked a question about one of our favorite tests, the children's communication checklist. So it's probably quite interesting to bring that in here. I know we talk about it a lot when we're working together. So somebody's asked here, is the children's communication checklist good for diagnosing DLD and ASD? And I think what they mean is probably one or the other. Obviously, we can't go into too much detail about the tests, but for anyone who's looking at the children's communication checklist, or who might be having that test, or who might have had a speech and language therapist use that on their child, have you got anything to say around that? Because there seems to be a lot of confusion in the Q&As about DLD, ASD and language difficulties all kind of amalgamating into one.
Together, yeah. Well, the Children's Communication Checklist, or CCC-2, is a screen. It's not, strictly speaking, a test. It's a questionnaire that comprises of 70 items that looks to see what a child's structural language skills are like. So what are their speech skills like? What are their what's their vocabulary like? Their semantics, their ability to produce coherent, logical responses, versus their ability to initiate an interaction, to understand contextual cues. And we routinely use this questionnaire when we're trying to gather further information about a child's presentation. And it has the function of allowing us to see whether or not a child might be presenting with what we called a language impairment, so a language disorder or a DLD, as opposed to an autistic spectrum condition. Now, in order for the child to be considered to have an autistic spectrum condition, there is something called the social interaction deviance composite, or the SIDIC. And if you get a negative score on the SIDIC, that suggests that the child's difficulties may be falling into the realm of an autistic spectrum disorder. However, if the child gets a positive SIDIC that is over, I think that the key number here is 9, if they get a positive SIDIC over 9 and a general communication composite, or the GCC, falls at 55 or below, then that typifies a presentation that is more language disordered. So it's useful in that respect, but I think it would be wrong of me to suggest that you could simply rely upon the results of the CCC-2 on its own. It would form part of a series of tools that you were using to gather information about the child and the way in which they presented. I use it quite a lot, but alongside other standardized assessments, as well as my own observations of that child and information that I may have gathered from previous speech and language therapy assessments, cognitive assessments, psychiatric assessments of the child, and so on and so forth. It helps you form part of the picture, but I wouldn't feel confident to say it's a standalone test. It's not designed.
That's really helpful.
For that.
One of the things that we're also getting asked quite a lot of, we've probably got space for just a couple more questions to get everybody finished on time. And thank you all for joining us this evening. I hope you're finding it really helpful. Something that we do obviously work on, Juanita, in the realm that we work in together, and certainly something that you can perhaps add as a treating therapist as well, is somebody's asked here, and obviously every child is different. I have to say that before we start off. Every child, even if they've all got DLD, if they've all got autism, they will still have very different needs. Just because they have the same diagnosis doesn't mean they present in the same way. And I think that's important to understand when we're asking these kind of questions. But the question is, what support would you expect to be given to a child with a developmental language disorder? And I think we could probably break that down, because that person's probably asking because their child or young person isn't getting anything right now, as we see quite often. And obviously there are very different ends of the spectrum. We've got some students that go to very independent speech and language therapy schools because they need a higher level of intervention. But perhaps if you could just kind of give an overview of what you might expect to see in an EHC plan for a child. And obviously that will vary depending on the severity of their needs, their age, etc. But any insight that you could give, both as a treating therapist and obviously doing the expert work as well.
Yes, I'll do my best. I mean, I think that given the nature of a DLD as a long-lasting and in some circumstances persisting, ongoing language disorder, for a child who has that sort of presentation, my expectation would be that they were receiving regular, direct speech and language therapy that was delivered by a speech and language therapist with training and experience in supporting children with language disorder. that very much differs from the type of support that perhaps a child with a less significant language disorder might receive within their EHCP. It might well be that they can access a program that is drafted by a speech and language therapist, but delivered by a teaching assistant, with the speech and language therapist having an overview and regular involvement with that program to ensure that it's actually meeting the needs of the child. I've got to say, in the course of my work, I tend to meet the children at the more severe end of things, who are perhaps, for one reason or another, not receiving that regular, direct speech and language therapy. And then when we actually look at the progress that that child might have made over a year or a couple of years, it's negligible. Hence, the reason why I would certainly advocate that they require a much higher level of intervention that was quite intensive and specific to their needs. And that might mean that their needs cannot be met within a typical mainstream environment, because for that sort of child or young person, it's not just about the weekly direct speech and language therapy, but it's about the integrated and embedded support for their language that goes right across their curriculum. And that, I'm afraid, is something that is not readily deliverable, in my view, within a mainstream setting. For those children, we often have to look at the more specialist, and they tend to be independent provisions where they have a significant number of speech and language therapists on site and as part of their multidisciplinary team, working within classes, co-delivering the curriculum, as well as supporting those children in therapeutic interventions. So I sort of hope that answers the question. Essentially, the more severe the challenge in terms of the language disorder or the developmental language disorder, the higher the level of need is what I would envisage and anticipate.
Thank you for that, Juanita. I actually think that's very helpful for lots of the questions that we've had. There are still a lot of questions open. I will just pick one more because obviously the time that we're on. And I hope that we can end this on a more, positive, give hope to parents as well around some of these questions, but also be realistic with the advice that we're giving. So somebody's actually asked, do the symptoms of DLD change over time, and can it get better with age? I'm not sure if you want to give an answer of that. You've obviously treated many students, young and older. So thoughts on DLD over time and whether it can change, probably not necessarily in age, I'm going to say, but obviously with the support available as well.
It's been my experience that if a child has been diagnosed with DLD and they receive an appropriate level of support to meet their needs, then we do see very positive and encouraging developments in terms of their DLD. Whether it always goes away, I think there are always some residual language difficulties. Language in itself is something that we as adults are constantly developing. I mean, we do not stop acquiring language. And so there are often some difficulties that we see continue into adulthood. But, I think back to the example of the young man who I bumped into in the local pizzeria. I mean, I remember our speech and language therapy sessions. And this was a young man that at the time I was seeing twice, possibly even 3 times a week at the height of his difficulties. and he's now holding down a responsible job. He actually manages the pizzeria. It was fantastic to see. And so I think that, yes, I mean, you know, it is encouraging on both counts for those children who have been diagnosed with DLD. The future is bright, albeit with the right levels of support. And likewise for those children and young people who have diagnoses of ASD. Again, if they receive the right level of support, we can see marked and quite considerable changes. And I think that's why I certainly do the job that I do. I very much believe in therapy. I've seen the value of it. It's a shame that it isn't perhaps as widely available nationally for as many children that require it, but it makes it even more important for those children who have the most significant needs, that those needs are recognised and that they get the appropriate levels of support, because, you know, we want these young people to have positive futures, to take their place in society, and ultimately be as independent as they possibly can be.
Thank you so much for that, Juanita. Sorry, we do have lots and lots of questions coming in on the Q&A, and Juanita knows as well as I could sit and talk to her all night and pick her brain around speech and language therapy. So thank you very much for giving up your time, Juanita. It's greatly appreciated.
Pleasure.
If any of you have been listening to this and have enjoyed the session and want to listen back, or if you think any of your friends or schools, etc., might find it useful, then we are posting a recording of this session onto our website and our YouTube channel, and that will be going up later this evening or tomorrow. We try to get them up as quickly as we possibly can. Please do reach out to us and do post on our social media channels if you find them useful. It's really helpful for us to know what is helpful for you as parents, so that we can continue to provide the things that are helpful. Everybody gives up their time completely free of charge to help you with these webinars. So we're really grateful for any feedback if you found the sessions helpful. So just thank you again, Juanita, very much appreciated from our side, and clarified lots of things on the Q&As, and I can see lots of positive feedback coming through. So thank you very much.
Great, fantastic. No, thank you, everybody.